everyone, and welcome to the next edition of the Academy by Acclivity Health Solutions. Today, we're going to specifically jump directly into how do the payment models work inside of value-based care. And so the only content I'm really going to share today is a single chart. We're going to jump right into that chart and really talk about what the market looks at, how models get sort of built, what are the things that are important, how do we succeed, what matters. And so what we've built here is a brief history about where certain things that exist inside of the last decade or so of payment methodologies. Where do they exist? And I want to orient you to the axes that are on this chart. So at the top and bottom of the vertical axes is the level of risk. So if you're nearer the top of this chart, you are taking on more risk. Think of it as not just your own particular care delivery and how much that might be professional services. So think in-clinic, traditionally Part B in Medicare language. Like it's not just the professional risk, you're taking on the global risk of those patients. If you're nearer the top of this chart, if you're nearer the bottom, then the chassis that the plan design is built around is fee for service. So there would be a fee schedule, and it's really a volume game with some perks tied to it. If you're on the left side, not only is it potentially that your payment is paid along this risk vertical, but on the left side of this chart really is it transactional or episodic? And on the right side of this chart, is it integrated or sort of health maintenance focused, population health focused? All right, so now we've oriented you to the 4 block here. So where most of the money in these models and where most premium dollars get sort of paid out in the model design is in the top right quadrant. So more risk and more of an integrated care delivery model. So if you're an integrated delivery network who has built its own health plan, they've often gone and got Knox-Keene or some sort of state regulation requirements met to be a health plan, then you truly are attempting to deliver an integrated delivery network approach to care, where you often would take your employees, like all your clinicians, your staff, into that model first, and then you'd offer that as an anchor to the industries around you. So this has been a long-standing model for some of the biggest organizations that deliver under this model. You'll know them by name: Kaiser Permanente, UPMC, Montefiore in New York, a whole host of them. Geisinger. So this is a well-traveled path. This is probably the most integrated and full risk model at scale in the wild that you could find today. There are models that mimic it. So if you look just adjacent to that is the ACO REACH models. REACH ACOs really are a very similar approach to care delivery when built in an employed model. So think about an organization that employs almost all of its clinical team members. Maybe they contract for pieces, but they could take that into REACH. It sidesteps a lot of the insurance regulatory requirements of the state because it's a national program rolled out by Medicare. But the aim here is the same. There is an expectation of managing global spend. As you move further left towards transactional care or further down on this, you will see that you start moving into things that also are Medicare models. So NextGen was a Medicare model. Primary Care First was a Medicare model. Global capitation is a largely MedAdvantage type model where they'd say Humana Gold, a great example. I will give you the opportunity to capture more upside, but you are going to be delegated for the entire spend or global spend for that patient population. And I'm going to pay you in 2 big blocks. I'm going to pay you capitation or monthly payments based upon the total cost of these patients. And every time you create a difference between the benchmark we've given you, think of that as the budget, and the pay that you're actually expending in total cost for these, we'll pay you that in bonus. So you're going to get a capitated amount, which is like just having the responsibility of caring for these patients. Think of it as a per member, a payment amount each month. And then the more you can increase the difference between the benchmark, the limbo bar, and how much you come under it, then that'll get paid out as bonuses. So that's a global capitation arrangement with payments tied to bonus for behaviors of reducing total cost of care or medical loss ratio. Primary care first is a bit like a traditional MSSP, except for instead of having to have a lot of the governance and components related to the ACO, that part's stripped away. Primary care first itself also pays capitation. So there's this concept of really being more paid based upon how you're actually expected to treat patients. 4 levels of risk in that arrangement based upon the level of need of the patient. So risk group 1 was making $28 PMPM in capitation. Risk group 2 was $45. Risk group 3 was $100. Risk group 4 is $175. So the persons that are in risk group 4, often house calls practices, they might be groups 3 or 4. Patients that are in geriatric practices are probably level 2 in that world, and maybe into the 3s, depending upon what your panel looks like. And then traditional primary care that see, internal medicine or primary care or family medicine as the core, and they're delivering everything from peds to geriatric care. They're probably a level 1 or level 2. And so that program, again, takes some benefits and parts of scenarios that are rolled out across this particular arrangement, as you see here. So there's different flavors of these kinds of models. When you get below the line, you're in a fee-for-service chassis. And so you would see traditional MSSP lives here because MSSP is often a fee-for-service plus bonus. You may see other kinds of networks that get built around, very specific service provision. You could see bundles that come out, as you imagine. You could see Med Advantage, which has some very specific sort of payment methodologies that align to risk. You can be delegated for risk or capitated for risk. And so we try to give an example of sort of what these are and how they fit on the spectrum between full risk at the top and fee-for-service at the bottom, transactional in nature on one side of the quadrant, and then integrated as sort of the other side. When you sort of look at the landscape, there will be more growth here in this quadrant and far less growth on this side. And so again, this was, just getting our feet wet. We'll spend a little bit more time talking about payment models over time through the Academy. If you have questions about this concept or these concepts, info@acclivityhealth.com. If you're interested in having us do specific Academy content for you, we'll gladly take your suggestions at info@acclivityhealth.com. Thanks. See you soon.